Our next speaker is Lisa Tito, and she's the director for the breast center here in Santa Rosa. It's a pleasure to have her. She's an East Coaster, Ivy Leaguer, went to Dartmouth, trained in Cooperstown, and if you haven't been to Cooperstown, I highly recommend you go. Not only is the Baseball Hall of Fame there, but they've got a phenomenal golf course right on the water. It's a great town, wonderful place in Western New York. Dr. Tito, come on up.
Oh, this is tilted. How should I screen for breast cancer? It seems like such a simple question. However, wait a minute. Wait for it. Not working. Oh, it is. Sorry, wrong way. Okay, sorry about that. All right, here we go. There are recommendations right now that say you should start screening a woman at age 40, go every year, annually. There are other people who say, well, think about screening from 40 to 50, but you don't really have to start screening until the age of 50. Then when you start screening, go every 2 years until the age of 75, and then we don't know what to do. There are other recommendations that say, well, think about screening from 40 to 45. Definitely start screening at 45. Go every single solitary year till you hit 55. Then you can think about going every 2 years. And you know what? We're living longer, so evaluate their life expectancy. If they're going to live for greater than 10 years, keep screening. So what are you guys supposed to do? What do you tell your patients? Well, one thing we need to do is look at why those recommendations exist. So these are recommendations that are still recommended by a lot of organizations, including the American Radiology Group. And these are how we started screening women when we rolled out the screening protocols in the 1980s. Start at 40, continue every year. And we kept doing that until the US Preventative Task Force was actually tasked for looking at all our screening recommendations for cancer and saying, are we doing a good job? So they looked at breast cancer screening. And their conclusion after looking at a lot of data was the women between 40 and 50 were actually maybe doing too much harm for too little benefit. And we shouldn't start screening the general population until the age of 50, then do it every 2 years. When they dropped these recommendations, there was a huge outcry from almost all of the organizations for a variety of different reasons. But the two major ones were, number one, they did not include anything other than film mammography when they were looking at the data. And it's just not good enough. By that point when these came out, most of us were using digital mammogram, let alone 3D tomosynthesis. Number two, they didn't account for the difference in biology between premenopausal breast cancers and postmenopausal breast cancers. They're not the same. Someone with premenopausal breast cancer, those cancers grow quicker, and when they get bigger, they tend to get worse, more aggressive. Now, postmenopausal breast cancers, they do grow a bit slower, the average ones, and even when they get bigger, they often don't get overly aggressive. So they're not the same. So those women between the 40 and 50-year-olds, they're the one that we need to screen to save lives. And there are many studies that we'll look at a little bit later about saving lives. So everyone basically said, we don't agree with these recommendations. However, it did make us pause and think and say, hey, wait a minute, maybe we should start looking at this a little bit differently because maybe we aren't appropriately screening women. So the American Cancer Society came out with recommendations. And what they did is they did not lump all the 40 to 50-year-olds together in the same group because they recognized, as you've probably seen, there's a bell-shaped curve for incidence of breast cancer. And between 40 and 50, it really starts going up right around 45. So much so that when I see someone in my office with breast cancer below that age, like 42, I actually start thinking of other causes of breast cancer, such as a genetic mutation. Because really, you tend to see most, not all, but most cancers really start after that age. The American Cancer Society also recognized premenopausal cancer is different. It does grow faster. We need to screen those women more frequently. So they recommended starting at 45, thinking about it between 40 and 45. Definitely start at 45. Do it every single year until 55. What does that do? It gets most women after menopause. Then you can consider going to every 2 years. After the age of 75, they recognize we're getting older and we're healthy. I had someone in my office right now, 87 years old. She's still going on cruises, hiking, doing amazing things. She's healthy as can be. So look at their life expectancy. If their life expectancy is greater than 10 years, keep screening them. But the critical thing that you always have to remember is these are recommendations based on the average risk patient. So what you have to ask yourself is, when a woman hits 55, postmenopausal, is she average risk? Can I now consider going down to every 2 years because I recognize the tumor biology often grows slower, we have a little bit more time, maybe it's safe, but this is only for average risk patients. So what's included in risk? Well, lots of things. You got to look at their family history. You have to look at their GYN history. Did they have children? How old were they when they had children? When did they start their menstrual cycles? When did they go through menopause? Is there any history of atypia? Atypical ductal hyperplasia, atypical lobular hyperplasia, LCIS? What does their mammogram look like? Yeah, you got to look at their mammograms. Is it very dense still because they're on hormone replacement therapy? Or is it not dense but has this incredibly nodular pattern? Why is that important? There could be a cancer hiding in there right now. So if you can't say your mammogram's clear right now, you got to keep screening them every year. Now there's lots of tools you can use to look at their risk, different risk assessment tools that'll give you a number for their lifetime risk of developing breast cancer. If your patient has a lifetime risk greater than 15%, they're not considered average risk. You should keep screening them every year. And if you're not sure where your patient falls, average risk, not average risk, it's okay to continue screening every year. But those are the things you need to think about. So what do we have available to us? Very briefly, mammography is still the gold standard for screening the general population for breast cancer. Most people have digital mammograms, and a lot of people are converting to 3D tomosynthesis. The advantage of the 3D machine is essentially instead of compressing your breast in 2 views, which just heaps breast tissue on top of each other, it actually takes slices through the breast, so it gives the radiologist the ability to screen through that breast. And what that does is it increases the sensitivity, so you find more breast cancers. And most amazingly, it also increases the specificity, meaning they can see something on the mammogram, and instead of getting all those extra views and sometimes biopsies, they can scroll through and say, you know what? That's normal breast tissue. I don't have to get more views. So it's a great technology, higher specificity and higher sensitivity. Amazing to have that combination. MRI is not a good screening tool for the average population. It finds too many normal things. You think we're over finding things in mammograms? You find about 3 times more normal things with breast MRI. But it is a wonderful tool because it does have a higher sensitivity. And we reserve this technology for the high-risk population, irregardless of breast density. And the high-risk population, genetic mutation, higher lifetime risk than 20 to 25%. Those are the group of women we're looking for to offer MRI for screening, not for the general population. I throw this slide up there because I see more of these here. Thermography is a technology based on the concept that if a cancer is in a breast, the skin overlying that cancer is going to have a higher temperature. So they looked at this technology in the 1970s, and they found it was not an adequate screening modality to detect cancer in the general population. However, it was FDA approved in 2006 as a safe technology, not as an effective technology for breast cancer screening. And the FDA felt in 2011 they had to issue a statement saying essentially thermography is not a replacement for mammograms and is not an effective screening tool for breast cancer. So please feel free to share this with your patients. If they want to get thermography, let them get thermography, but don't substitute it for mammography. Bigger question, should we even be screening women for breast cancer? Why do we screen? Well, the purpose of any screening is to find a breast cancer years before it becomes clinically apparent, so that we can potentially offer less surgery, less radiation therapy, and less chemotherapy, and to save a woman's life. However, we have to balance it with the harms of any screening modality. And for mammographies, there are a lot of false alarms, meaning extra testing, which causes undue anxiety, and this whole concept of overdiagnosis, which I'm going to talk about in a few minutes. So how are we doing for breast cancer at presentation? Well, yeah, you can see that. 1950, obviously pre-screening, when a woman presented for breast cancer, the average size of her cancer was 3.5 centimeters. And over 60% of the women presented with positive axillary adenopathy. Rolled out screening in the 1980s, and we started to see the tumor size at presentation decrease. And by 2006, the average size of a breast cancer was 2 centimeters. And less than 30% of women presented with metastatic disease in their axilla. It seemed to be working. And what does that mean to me as a surgeon? Well, if I see a woman with a cancer this big, it's hard to take it out of her breast and leave her with normal breast tissue. More likely to need a mastectomy, bigger surgery, reconstruction. If she has small disease, she's less likely to have axillary lymph node disease. I am able to do less surgery in her axilla. Significantly less risk of lymphedema. Makes a difference for me. We also know that if it's smaller and a woman is older and I am able to get nice wide margins, which I'm more likely to do if it's a small cancer, we can now ask someone to say, listen, you might not even need radiation therapy, so they get less treatment. And what about grade at presentation? There are studies showing that if you get breast cancer and you're in the screened population, you're more likely to have a better differentiated tumor than if you get breast cancer and you weren't screened. You're more likely to present with a poorly differentiated tumor. And that often changes the systemic treatment that breast cancer has to have. So well-differentiated tumors, more likely to have aromatase inhibitor or tamoxifen. Poorly differentiated tumors, more likely to need chemotherapy. Next question, do they save lives? Absolutely, positively, mammograms save women's lives. Every trial looking at this question has found that, including the US Preventative Task Force. They published a 15% improvement in mortality if your woman in your office gets breast cancer and she's in the screened population. That's astounding. They should have been celebrating that. Because I want to give you a little bit of perspective. If a woman is offered systemic chemotherapy, she is likely to say yes to having toxic chemotherapy if we can offer her in a 2 to 3% improvement in her survival. Her hair is going to fall out. She's not going to feel very well. She has to have chemicals that are toxic going into her bloodstream. And she will say, yep, I'll do that. 3% improvement in survival? Yeah, I'm there. Mammograms will improve her survival if she gets breast cancer by 15 to 30%. Amazing. Yeah, you have to be squished. It hurts a little bit. Not too bad. This was an interesting study in 2006 looking at the difference in mortality reduction over the United States. Let me see if I can get this to work. Does that work up there? No. Okay. So, if you look at these 3 states, they saw a 40 to almost 50% reduction in mortality compared to these 3 states, which only saw during the same time period, same access to chemotherapy regimens, only 11 to 14% reduction in mortality. What was the difference? three biggest adapters of screening their state's population with mammography. These, three of the four lowest adapters of screening mammography. Same systemic therapy. I worked with Dr. Blake Cady in Rhode Island. He's a world-renowned breast surgeon, and he looked at some data because Rhode Island, very small state, they had this unique experience. In the 1970s, they were funded to screen the state. So they did. And what they noticed is about 3 to 4 years later, they saw a drop in their mortality for breast cancer. Not across the country, but in Rhode Island. And then their funding ran out. Screening was de-emphasized. They started to see the mortality going back up over time until it had baseline again up to where the rest of the state, America, was doing. Then the 1980s again rolled out and everyone said, okay, screening is a good idea. They saw that mortality again, just like the rest of the country, started going back down. Mammography. So what do we know about screening mammography? Well, if your patient develops breast cancer and you have been screening her, you have improved her survival by 15 to 30%. You've given her the opportunity to potentially have less surgery, less radiation therapy, and less systemic therapy. That's a good thing. But we do have to balance it with this whole thing of harm. So what harm do we do with screening mammographies? Well, there's a lot of false alarms, which means extra studies that have to be done, extra biopsies, and undue anxiety that we're causing by our screening mammograms. So here is a chart which essentially shows, it's looking at 1,000 women in different age groups. This is 40 to 50, 50 to 60, 60 to 70. And watching them over 10 years of getting their mammograms every year. What happens? Well, this is the amount of extra procedures or testing that are done to them, which generates the appropriate amount of biopsies, which then finds the breast cancers and saves, by this estimate, a few more lives because they were screened. That's a lot of testing, causing a lot of undue anxiety. Yeah, it does happen. And this is the bar that I think all of us in the room have the ability to help our patients and counter this undue anxiety. And this is something we can do, well, not tomorrow, but Monday. Prepare your patients. Prepare them for their mammograms. The role of mammograms is to find things in your breast. They're supposed to find things. The breasts have tons of things in them. Most of them are not cancer. However, we have to do extra studies to prove that they're not cancer. That's one of the downsides of mammograms. And yes, you have lots of normal things in your breast. You might even make it all the way down the path to a biopsy. But even if you make it to that biopsy, way down that path, 85% of the time, it's still not a breast cancer. So we can help reduce that anxiety that we do cause by all those extra studies. How about overdiagnosis? What this means is essentially the diagnosis of conditions that would not have become clinically significant if not detected by screening. So what's that do? Leads to unnecessary testing, unnecessary treatment, and psychological consequences, meaning, oh my gosh, I had breast cancer. They think about that all the time now. So essentially what it is cancers that never would have showed themselves, and this DCIS, which I'll get to. But how the heck do we figure that out? Because you can't really know which cancers weren't going to be clinically relevant or not. So there's all different ways we can estimate that concept of overdiagnosis. And one way is to, essentially, we have an incidence of breast cancer prior to starting a screening regimen. If we start screening our population, we all expect that we're going to see a rise in the incidence because we're taking all of these breast cancers that we're going to find down here and we're moving them into this group. So we expect to see a bump in the incidence of breast cancer, right? But then what we expect to do is that incidence comes down, back down to normal, or where we expect that incidence to be later as we start screening the population and got rid of all these lead time bias cancers. Now, if that incidence is higher than we anticipated, or higher than the non-screened population, that could be the overdiagnosed breast cancers, or there could be another cause of an increased incidence, such as aging population, obesity crisis, decrease in activity in a country, earlier onset of menstrual cycles, later onset of menopause, more hormone replacement therapy use. I don't know any country like that. That could be happening too. But that's one way to look at this concept of overdiagnosis. The other way to look at it is, if we're doing our job, we should be finding more breast cancers earlier, right? And when we find them earlier and treat them, we should see a drop in late-stage breast cancers because we've already treated those ones. They didn't have time to become and progress to late-stage breast cancers. So let's look at a couple studies. First of all, the whole overdiagnosis. This is a list of countries across the world reporting overdiagnosis. There's a lot of them. If you take them all together, the rate of overdiagnosis is about 20%. But I also want to add, these are also the same countries that report that if your patient gets breast cancer and she's in the screened population, you're going to improve her chance of surviving that breast cancer. Now I want to show you some data that was done looking at SEER data. And they were looking at this question of overdiagnosis. Are we doing a good job or not doing a good job of screening our population? So they looked at the population from 1977 to 1979, pre-screening population, compared them to 2007, 2009, well into our screening. And what they concluded was that there was a 33% rate of overdiagnosis of cancers that we may or may not have needed to do anything about. They saw an increase in early stage breast cancers. They didn't separate DCIS and invasive out, but they saw a lot of early stage breast cancers, which we expect. But they didn't see the reduction in the late stage breast cancers that we anticipate if we're doing a good job of preventing progression of disease by screening and treating those cancers earlier. So this was somewhat of a blow to a lot of people around the world and our country who believe that mammograms save lives. You're like, okay, how do you explain that? That's pretty impressive. Well, remember, these are all estimates based on certain assumptions. And one of those assumptions is something called the annual percentage change, or APC, which is across the world, including our country, we expect and we are seeing an increase of incidence of breast cancer naturally outside of screening. This study used the APC of 0.5% when they did their fancy math. So people started looking at that assumption and recalculated the APC for our country and other countries using 5 different models. And they all came to the same conclusion. The APC in America was more around 1.2%. Europe was about 1.6%. Africa, which doesn't really get screened, theirs is like 3 to 4%. They've really seen an upshot of breast cancers there. Then they recalculated everything. Same data. And this is what they found. All right, so what did they find? They actually saw that the incidence of breast cancer was lower than we expected. Not 33% overdiagnosis, lower than we expected. They also saw a 37% reduction in late-stage breast cancers, with, importantly, a reciprocal increase in early-stage breast cancers, and, this will work, there we go, approximately the same decrease in mortality that mirrored the reduction of late-stage breast cancers, just like it should be. So they used the same process of math and looked at, someone did a trial looking at, yeah, there we go. They looked at the European data. They looked at 13 trials over in Europe that were showing overdiagnosis, and recalculated it and looked at the rate was really only 1, maybe up to 10% of this potential overdiagnosis, significantly less than we thought it potentially was based on those other models. The Canadian trial, I don't have enough time to go into that. You saw my little editorial on my other slides to try and sear it into your brain. But one of the things about the Canadian trial is when they published their poor data 25 years later, still poor data, they reported a 22% overdiagnosis rate. Someone actually looked at their actual numbers in the paper itself in a graph and did their math and said, wait, no, it's 4%. Your own numbers is 4%. Maybe screening works. However, DCIS, stage 0 breast cancer, we've seen a huge increase in the diagnosis of DCIS as we've gotten better with screening mammography. Are we overtreating DCIS? Yeah. Why? Come on. We're not smart enough not to. We're not there yet. We don't know which of those non-invasive cancers are going to learn how to become invasive breast cancers. We don't have those biomarkers yet. We've looked at tons of different things that we thought we'd say, hey, older woman, low grade, tiny. Nope. Still could turn into a breast cancer. So we are overtreating DCIS right now because we're not going to leave it in a woman's breast and say, I don't know if it's going to turn into breast cancer or not. Good luck. We'll see you back in a few years if it's growing, because I can do a simple, easy operation to take care of this. It takes me 40 minutes. She goes home, often don't even need radiation therapy, and all she needed was my surgery, as opposed to waiting to see if it turns into an invasive cancer that might still, at this point now, need radiation therapy, bigger surgery, maybe even systemic therapy. Yeah, I can take care of it right now, and I'm going to. Until we find those modalities of identifying that subset of DCIS that do not progress to invasive disease, and they do exist. There's some good trials going on right now. The LORIS trial is being done looking at that question. We're all hoping that that answer is here soon. But right now, we're not there. I know there's some people, even actually in San Francisco, have been looking at watching people with DCIS right now. You know what? All the studies looking at that so far, we can't find those people. They are getting invasive disease. We're not good enough yet, but we're gonna be. Be patient with us. Can you go back one? Okay. So one thing I also think is very important is that a woman is an important part of the decision of what she does with her body. We do have to bring her into this conversation. So I look at it this way. When I'm talking about screening mammograms, I'm a surgeon, right? I goes, what's the worst possible thing that can happen? And then let's back up from that. So what is the worst possible thing for a woman if she makes her decision to be screened, starting with screened. So she chooses screening mammography for every year until whenever. What's the worst thing that could happen? Well, she doesn't get breast cancer, and she didn't need to be screened. That is the worst thing that could happen in that situation. So what are the downsides of that choice if she's in that group? Well, it's uncomfortable getting mammograms. I've been there, done that. It hurts a little bit, but it's quick. It does generate additional views. Yeah, we saw that, but we're going to do our job to prepare them so they don't get anxious about those views, because they're coming. Sometimes they even make it to biopsy, but remember, 85% of the time, still not breast cancer. We're going to counter that undue anxiety. Maybe we're discovering breast cancers that we didn't know didn't need to treat, but I don't know which ones are which. And again, California is different. You're not causing breast cancers because you're getting screened. Risk of radiation causing her breast cancer less than 0.016. We can write that down. Let's say the other situation. She chooses, I'm not going to get my mammogram. What's the worst case that can happen to her if she makes that choice? Oh, she gets breast cancer. Of course, that's the worst case in that scenario. So what happens then? Well, she has a 15 to 30% higher chance of dying of her disease now. She potentially has to have larger surgery, increased risk of getting chemotherapy, definitely is probably going to need radiation therapy. Those are real things. I didn't do that. You did, okay. All right, no problem, no problem. Okay, why am I giving this talk? Well, as they said, I'm from Massachusetts. I used to run the Beth Israel Deaconess Breast Program in Plymouth, Mass. And we moved here in August, just prior to the fires. And I've noticed a big difference in the cancers that I'm seeing in my office just since August. And again, take out October, so I haven't been here that long. They're different here. I'm seeing much larger cancers. I'm seeing people with more metastatic disease, young people with metastatic disease. And these are the people, they're not getting screened. And I know there's a ton of reasons why they're not getting screened. I'm getting that. I know about Sebastopol. I know about Eureka. I'm seeing those people. They get big cancers. And I know we can't get to everyone. But I'm putting out to you guys to help. See if you can get more women screened, because the cancer presentation here is different than when I saw in Massachusetts. So many more people were getting screened. It was rare that I saw big cancer. It's rare, I'm shocked when I get a normal cancer. It's like, oh my God, this is a mammography detected little 7mm cancer. Yeah. That's what I'm asking for you guys to do, is help. Let's see if we can do a better job screening our population. So to conclude, lots of recommendations out there. I'm a fan of the American Cancer Societies, but there's different recommendations. Start thinking about the question at age 40 and having that conversation with your patients. By 45, though, definitely start screening them every single year, because the cancers act differently. Go until 55, you get them all through menopause. Then, if their average risk and their mammograms are easy to see through, you can consider going to every 2 years. That is probably safe, but you gotta be sure. And if not, keep going every year. Stop when their life expectancy is less than 5 to 10 years, because the purpose of mammograms is to prevent a problem in the future. If they don't have that future, stop screening them. And when you're discussing the pros and cons of screening, use that approach to say, what's the worst case scenario if you don't get screened? Well, you get cancer and your mortality goes up. I have 3 minutes. All right, I'll stop there. Questions?
Doctor.
How much downside if you do every year?
How much downside if you do a mammogram screening? It means if you screen every year, you are going to get more false positives, meaning you are going to get more views that have to be done. Again, this whole concept of overdiagnosis, I know people talk about it all the time. Yeah, we might be treating cancers we didn't need to, but you know what? We don't know, really still don't know what that means. So I don't see a lot of downside to doing it every year, to be honest with you. I'm fine with you guys screening every year. 3D is so much better. I mean, again, you don't have to make a patient drive for 3D mammograms, and if your place only has digital, it is okay to use digital. It's great technology, but 3D has the advantage: increased sensitivity, finds more cancers, and less workups. 15% less chance they need a workup. It is a better technology for that reason, but you don't have to really search completely for it. But if you have it, yeah, it's good.
The radiation,
0.016. It is not significant. Again, like I told you, difference East Coast, West Coast, we didn't even hear that question. Yeah, but it is what it is. We have to work with that.
Following on that question,
Yeah.
the slide that you had about the 0.016, so I'm in Mendocino, we are. I don't know if you know about Mendo yet.
Yeah.
My patients are gonna ask me, was that you're not going to cause breast cancer, or you're not going to cause my thyroid cancer or my lung cancer, you know?
Can you give me back my thing, or go to, I actually anticipated a little bit more questions on that. Natural exposure, every year just by living in America is 3, whatever MSV is, 3, okay? If you live in a plateau, like in Colorado or New Mexico, add another 1. Just because you live, all right? Abdominal pelvic CT, because when they hear about all those things causing cancer, what we're really talking about is CT scanning. 10. That's high. So yeah, do we need to get CT scans sometimes? Yeah, but that's when we as doctors should be thinking about over-radiating. And that's where the studies have been showing those changes in cancers. Mammogram, 0.4. So yes, no, that it is okay. It
The
truly
following, just the last thing about that is, that's based on annual screening mammogram?
Annual screening mammogram.
Okay, great.
And then the follow-up question before you get to digital, what's the difference between the 3D versus 2D mammograms? They're going to ask you that. The technology right now that does a combination of 2D mammogram view, so they do the compression, and then they go through the slices. So there is a slightly higher dose of radiation therapy with the current format of 3D mammograms, but it's just slightly higher. And then if you put it in perspective, but you're also going to be doing less views. So if you look at the long-term effect of the radiation dose over a period of time, it's probably going to be about the same or less. And we're eventually going to be dropping the 2D component of the 3D mammogram. And once we drop that, it actually has a lower dose of radiation therapy compared to a digital mammogram.
Dr. Tito, thank you for your remarks. We all have had the experience of those horror stories of the 30-year-old or the 35-year-old that gets a bad breast cancer. Do you have any screening recommendations for them, specifically the use of genetic testing or aberrations to when you start screening for certain populations?
Right. So all the recommendations I just went through are only for the average risk population. What you have to do, and it's hard, and I understand you guys have so much you have to do in your offices, but family history is key. And we're asking family history for the patients, not because we really think breast cancer is linked to family history, because it really isn't, but we're looking for that needle in the haystack. And the only way we find the needle in the haystack, which is a genetic mutation, is look at everyone's family history. If you see a family that has essentially like every generation on one side of the family that has young premenopausal breast cancer, less than 45, that should set off some red flags to send into either any of the programs around that have a genetic counselor or consider genetic testing. Because if you have a genetic mutation or a high-risk family, we do change our recommendations. Genetic mutations, we start screening at 25 with MRI. We then add also a mammogram. We alternate the two. You don't just do MRI. Even in the high-risk population, you still have to do mammograms because they see things differently. And you get that every year starting at the age of 25. Then we talk about ways to reduce their risk of breast cancer and stay in high-risk screening versus doing prophylactic surgeries. But that is something that you should always be looking for. Multiple generations, young breast cancer, maybe some ovarian cancer. We're rolling out, at Santa Rosa, we're rolling out a high-risk program actually a week from Monday. So your patients, if they come through our mammography suite, we're asking them questions, which is going to give us risk assessment scores, which are going to be reported on your mammogram reports now. You're going to see a NCI lifetime risk of developing breast cancer. If it's over 20 to 25%, they're going to be automatically offered an appointment to come meet with me to talk about if they're truly at higher risk and we should add MRI to their screening. We're also looking for red flags for a genetic mutation for you guys to help you, because we know it's hard for you to do it. We're going to help you with that. We'll pull them in as well to see if they need genetic testing. Oh, we got to go, sorry. Okay. I'll be here at lunch if you want questions.
Thanks, Dr. Tito, appreciate it. Very excellent presentation.